So I'm going to introduce our guest and my co-founder, Mahesh Jayaraman. As I tell people, Mahesh is a walking, talking encyclopedia on PCOS. And even though I have now worked with him for close to 5 years, 4 of them on PCOD, each time I have a conversation with him, there's always something new I hear. So, Mahesh, thank you. We're all looking forward to you sharing some truths, sharing some surprising facts that we don't know about PCOD, and also busting some myths. Can you hear me?
Thanks so much. Thank you, Sharda. I think it's the first time we're going live this late in India. I do hope that this is a convenient time for people, at the end of a work day, etc. Very happy to share our experiences with the 400 plus ladies who have put their trust in us and had their PCOS issues substantially addressed, if not reversed, and that too naturally. So, very happy to be here on this platform.
Yeah. So, one of the things that we've realized, and this is of course a well-known fact, Mahesh, that PCOD is so hard to diagnose. We often hear that almost 50% of the cases just don't get diagnosed because there are so many symptoms. So conventionally, what happens is a woman goes to a doctor because she has missed her periods, and usually the doctor will ask for an ultrasound scan or do a blood test to figure out either if there are cysts or hormones a little high on the blood test report, or if the woman reports symptom like an acne or periods. Okay, so once they look at these reports and the blood test or a scan, they prescribe certain medicines. So my question to you is, and I know that we've had this discussion at Sepalika, what is wrong with this conventional way of diagnosing that somebody has PCOD?
Okay, so a little bit of history on this quickly, which is that the term PCOS stands for polycystic ovary syndrome, right? And so what happened was that in the initial days when they were just discovering what PCOS was all about, they looked at the ovaries of ladies who had missed their periods and found that there were many small cysts on their ovaries and, almost forming the shape of a pearl necklace. And that's how the name polycystic ovarian syndrome or polycystic ovary disease, as we often call it in India, came about. But what first important myth to bust and for everybody to know is that almost every woman goes through this kind of appearance on her ovaries at least a few times in a year. So the cysts, we all think a cyst is a growth which shouldn't be there. But the term cyst is a little bit misleading here because all immature eggs inside, jelly-filled sac-like things on your ovary, each of those is called a cyst. So the trouble with diagnosing PCOS just from an ultrasound is that many women may have polycystic-looking ovaries, but they don't really have the disease. And at the same time, there are other women who have normal-looking ovaries and still have symptoms such as acne or excess body hair or missed periods or extremely painful periods, all of which could be PCOD. So in fact, there is a movement in the West to define PCOS better, to have a diagnosis which is better, and call it an androgen excess syndrome. So that is the first thing to know. Second thing to know is that all of us know that when you go to conventional treatment, once they've tried to address the PCOS a little bit by giving advice like, you must lose some weight or, you should not take so much stress and regular things that you're told, then even young women get put on birth control pills. And that to me is the problem, because even though it sounds like it's a gynecological problem and therefore it has to do with you must treat the reproductive system, our own experience has shown that the real causes of PCOS lie far deeper down, which is why we say there are many types of PCOS. So the solution cannot be just one.
So it can neither, usually most of our patients either have a birth control pill or metformin. That's the second most popular medicine. Since we discussed birth control pills, can you just take us through? So I want to do two questions, right? One is, what is the harm in taking a birth control pill? Because let's face it, we've seen so many of our patients come and tell us, you guys want to take me off the contraceptive pill? I've taken the pill, I managed to get regular periods. I've taken the pill, my acne has gone. And guess what? I've even taken the pill and lost weight. So, and you're telling me you can't use a contraceptive pill. So, give us the myth around the periods, so-called periods that a woman gets when she gets on the pill.
Yeah. So the first thing is, unfortunately, most young women in India, especially those who go from middle class families to a standard gynecologist sort of consult, get put on the pill without even being told that it's a contraceptive pill, right? So nobody knows. So, we are the only ones who keep saying, hey, you're on birth control pill. She says, no, no, no. I'm on a pill for PCOD. It's called Daisy. It's called Diane. It's called whatever brand name
Yasmin.
it is, Jasmine. So all very,
Yasmin.
nice sounding, very, flowery sorts of names. And unfortunately, they're not being told that what they're on is a birth control pill. And why do we have something against a birth control pill when it delivers such excellent results, right? So here's the issue. The birth control pill really doesn't address the root cause of your hormonal imbalance or your male hormones being excessive at all. All that the birth control pill does is it shuts off your own hormonal system and runs a bypass system using the chemicals inside the medicine itself. That is why, as soon as you go off the pill, so many women come back and tell us, hey, as soon as I went off the pill, my acne came back, my body hair came back, my periods went irregular, my weight became, all of it came back. So essentially, the trouble with the birth control pill is that it masks the symptoms and doesn't really fix whatever was wrong in the body in the first place. Secondly, and we've had our gynecologist, Dr. Pratnya Parulkar, who's, MD, OBGYN, come on camera and say this openly, that the bleed that a lady receives when she is on such pills isn't a real period. In technical terms, it's called a sympathetic bleed, and in just plain terms, it's called a false bleed. So, what's happening is it looks like a period, but it isn't really a period. And therefore, all we are doing is instead of identifying the root cause of the problem, we have merely put a band aid on top of it, and years later, it's going to lead to terrible consequences.
And one of the years later consequences that we've seen, at least at Sepalika, has been that women have come back to us with fertility issues because they think that just because I'm having a period a month after month regularly means I should be able to conceive. And when the conception issue hits them is when they realize that, that whole concept of an anovulatory period is, that dawns on them. So just, can you take us through this one side effect of the pill being the anovulatory period?
Absolutely. I mean, so, again, you've hit the nail on the head. So, this is almost like a typical journey, right? So, when women come to us in infertility, we will often hear that, at the age of 14 or 16, or maybe even as late as 24, once I started working, once the stresses of work started, I began having irregular periods. So, I went to my gynac. She put me on the pill, and my periods became perfectly regular. Then I got married at the age of 26 or 28, and then we've been trying for 2 years, but there's been, no success, and I don't know why this happened. What they don't realize is that in the first place, when you were getting the irregular periods, those periods were such that an egg wasn't being released in the period. So this needs a little bit of rewinding and a very quick understanding of what a 28-day period looks like, right? So day one, let's say, is when the bleed begins. You're supposed to have a bleed that's going to be a maximum of 5 or 6 days. In some women, it can be shorter, some women a day longer, but that's it. Once that is over, estrogen is the hormone that's building up the inner lining of your uterus and making sure that your ovary releases an egg around day 14 of that period. That egg is the possibility of a baby. So around day 14, as soon as the egg is released, a new hormone called progesterone begins to get secreted in the woman. And the job of progesterone is to make sure that the lovely endometrial layer that was created by the estrogen to house the baby, as well as the egg that was released on day 14, these are protected should the lady choose in the next 14 days to have a baby. This process is a normal process called ovulation, and then 14 days from ovulation roughly is when your period happens. This cycle repeats itself. It's only during ovulatory periods that you can get pregnant. And it is possible for a lady to have a normal cycle of 28 or 30 days wherein one bleed happens, let's say, at day 1, and 28 days later or 30 days later, she again gets a bleed. But in between, the all important event at day 14, which was the release of an egg, never happened. And here's the irony of it: the birth control pill literally mimics only the bleeds, it doesn't cause the ovulation to happen. So, when you are then going off the pill, despite having regular periods, and you think you can get pregnant, what you don't realize is all this while the pill was masking the fact that you weren't having ovulation during the period. And that leads to anovulatory periods and infertility.
So critical that young girls and women are educated about this fact that a birth control pill is almost like a band-aid. You're trying to mask or fix a symptom at a very superficial level, and assuming that women, as they get older, want to go on to conceive and have children. This can be so damaging for them on their health, right? The one of the earlier points you mentioned, Mahesh, at the start of this conversation, you refer to types of PCOD. As far as we are concerned, for most of us, PCOD means just lack of a period, or acne, or embarrassing face and body hair. What can you just take us through what you mean when you say there are different types of PCOD?
Absolutely. So, from a more holistic or naturopathic standpoint, we must remember, first of all, let's look at the name. It's called polycystic ovarian syndrome, right? The syndrome is the correct name for it because it's a bunch of symptoms that come together to form the syndrome. And the syndrome usually shows symptoms like irregular periods, weight gain, cystic acne, facial or body hair, even hoarseness of voice, infertility. These are all symptoms of a syndrome. Why is this so important? It's because all women come to us saying, my doctors told me lose weight and your PCOD will get fixed. That's really not where it's at. That form of PCOD, where you begin to put on a lot of weight, is often accompanied by insulin resistance or early stages of diabetes. That is the form of PCOD that's most common, but that's just one type of PCOD. The second type of subtype of PCOD that we have identified, and it's helped us treat women, is when it's a problem with the adrenal glands. So the adrenal glands are primarily our stress response system. So all day long, if you're in high stress and your cortisol is elevated and your stress hormones are elevated, and if you don't get proper sleep, then what's happening? As far as the body is concerned, it thinks you're in a fight or flight situation, which means your life is in danger. How can it allow you to reproduce when your life is in danger? So it's not going to allow you to release an egg or have a true period during such times. So that's the second kind. The third kind of PCOD, which we have found, is often in very thin women. And in thin women, this sort of syndrome will come when they have already excess male hormones in other people in the family. Usually a mother or an aunt would have already gone through this problem. So this is a genetic component of PCOD. And again, like you and I often say, genes only load the gun. It is the lifestyle that pulls the trigger. Dr. Mark Hyman, one of the great functional medicine practitioners, is often quoted with this particular, sort of saying. And the point here is, even genetic PCOD, if it's identified properly, can be fixed. And the fourth PCOD is sadly one that is truly caused by the doctor. So if early on in life you get put on to birth control pills, later on in life, irrespective of going off the pills, you may still not get regular periods. And this is called post-pill PCOD. So although as far as mainstream, sort of allopaths are concerned, there's only one kind of PCOD, when we treat it with a holistic diagnosis and a natural sort of cure, we look at 4 subtypes of PCOD, and it makes a difference how you treat it. For example, if it's an insulin resistance PCOD, taking just the processed carbs a little bit out of their diet, and you know this, Shata, as a nutritionist, just giving them the right proteins, the right fats, so instead of 4 rotis, 2 rotis, and with ghee on both sides, accompanied by a good quality protein at every meal, this can change the insulin resistance profile so much and immediately deliver results for insulin resistant PCOD. Whereas if somebody has come to us highly stressed, not sleeping properly, cortisol is an issue. When we test, when we run our blood test, the AM cortisol comes elevated. There, they need to do simple things like breathing, use supplements like ashwagandha that are safe for everybody, and then we are able to get their PCOD under control. If it's somebody with very high male hormones and therefore often body hair and stuff like that, and if it's a genetic component that's coming in, they need something called DHT blockers. So a simple spearmint tea, which we have used so effectively, just thrice a day, sip a cup of spearmint tea, which is so tasty, and it gives you the results of blocking over conversion of testosterone into a more virile form that's called DHT. That can lead to the PCOD symptoms all abating. And finally, when it's post-pill PCOD, unfortunately, since that one is created by chemical medicines, it takes longer, but we need to clean out the drugs that were there in the system and give the body a chance to realign itself to natural cycles. So that's how the subcategorization and the treatment all change with our subtypes of PCOD.
Yeah, and it tells me the importance of personalizing treatment for PCOD, especially if you want long lasting results, because otherwise, we often hear of people saying, oh, but my PCOD came back. It is possible to reverse PCOD. Reversal obviously is not curing, but reversal means so long as you follow a certain sustainable lifestyle, you should be able to keep away symptoms of PCOD, including you should be able to get pregnant. Sorry to bring in this, my favorite topic, but one of the biggest, issues, and because I talk to a lot of women, I mean, I know we've treated 500, but to treat those 500 women, I must have personally spoken to at least 2,000 of them. And one of the biggest concerns they have is that now that I have PCOD, will I be able to get pregnant? Because they've been told that your chances of pregnancy are hugely hampered or affected if you have PCOD. Is that true? And therefore, is artificial, reproduction treatment the only option?
Well, I think that artificial reproductive techniques certainly have their rightful place. There are couples, especially where the women may have certain structural issues, like a fallopian tube that's damaged or a uterus that's, kind of very lumpy or has adenomyosis beyond repair. But these are structural issues. The unfortunate part of today's modern world is as soon as you go to a gynac and you've tried, let's say, for 3 months or 6 months, and then the gynac begins you on follicular stimulation, with clomiphene, etc. I'm sure a lot of the people listening in may have heard of these things. And then it's IUI and it's IVF. Sepalika has till date had instances of 15 at least that we know of. We've treated hundreds, so we don't know how many have gone on to have children naturally. But these women were all told that you have PCOD, it's not curable. Several came to us after failed rounds of IUI, IVF, etc. And our PCOD they have fixed their lifestyle. I often tell patients, Shada, nature has only two dictums. There is just preservation and procreation. Nature just wants you to be really healthy and it wants you to produce children. Sorry to sound like all the other higher goals aren't really meant, but that's the truth. Nature in its natural form just has two things. So if you're having trouble conceiving, it most likely means that there is something else wrong with the underlying factors in your own health. Fix your own health, and natural reproduction, natural conception is a natural result. You don't really need to go into test tubes so easily. That's been our experience.
Yeah. So there was a question I just noticed, somebody asking how much of spearmint tea should I have? It's usually 2 cups of spearmint tea in a day. Buy the loose spearmint tea. You can buy them on Amazon and brew yourself a lovely cup. Sorry, just lost you, Mahesh, for a second.
Yeah, I realized that as well. So I stopped speaking. You can hear me clearly now, right? So, okay. So the spearmint tea therapeutically is to be had thrice a day. It's usually 5 grams. So it's a teaspoon that you put into hot water and you mix and you allow it to steep, and you can then strain it and have it. It has a fantastic taste, of course. It can replace all those endless cups of chai and coffee that we're forced to have socially or at work and so on. And thrice a day gives a lot of our patients wonderful results.
All right, thanks. Before I go on to my next question, we also had somebody ask, what is the role of LH or the luteinizing hormone with this question?
All right. Okay. So my apologies. I don't know. Maybe it's the Netflix time for a lot of people in my colony. So I might be getting limited amounts of bandwidth. But here we go. So luteinizing hormone or LH primarily has the task. It's a brain hormone. It's secreted from your pituitary gland, and its job is to tell your ovaries to actually mature to produce, eggs. So LH and FSH are the two hormones that are um, whose job it is to stimulate your ovaries to actually produce eggs. And in men as well, LH has a role. So LH in men has a role of actually stimulating their testicles to produce the sperm. So you've got the LH and FSH playing a role in both men and women.
Right. So, I mean, this is where I think I want to say that how often we think PCOD is purely about the reproductive organs, which is just, everybody thinks PCOD is about the uterus and it's about the ovaries. And this is something that we keep telling all our clients, the people who come to us on any of our programs, especially the hormone ones, that hormone production begins in the brain. And therefore, for us at Sepalika, it's a north to south process. So we start by looking at that entire, literally, it's the super highway between the brain and right down to the ovaries, in between going through your thyroid, your liver, your intestines. So that's the highway that we're taking. And there could be a traffic jam anywhere along that highway. What's the point in only looking at the, what's, stuck at the right at the end if the actual issue is somewhere in between? So thanks for talking about the hormone stimulation in the brain. There is one question, Mahesh, on what's the role of metformin? Somebody says that they've been prescribed metformin by their doctor for PCOD, but they don't seem to understand because metformin, as far as they've Googled, is a diabetes drug.
All right, this is a very good question. And certainly, if there is one allopathic drug that we would be happy to, sort of not vilify at Sepalika, at least, not say no to at Sepalika, it would probably be metformin. The reason for that is that metformin, although it's an allopathic medicine, its true roots are actually in Ayurveda, because metformin is actually nothing but the French lilac flower extract. That's where it comes from. So the beauty of metformin is that it improves your insulin resistance. So in women who have polycystic ovary disease, where the root cause is coming from insulin resistance, metformin is a good drug to use. However, remember I keep saying it's a drug. So don't use a medicine to cover up anything at all. Why did you get insulin resistance in the first place? Ask yourself that. Maybe those extra carbs that you're putting away or that extra dessert, is it really necessary? Is that the one that is stimulating this? So the way that insulin resistance PCOD works is like this. If you have too much sugar in your diet, or if your body is hypersensitive to sugar, then what's going to happen is that you're going to have a extra secretion of insulin to try and force the sugar into your cells. Now, while insulin peaks, at the same time, the male hormone testosterone also peaks. These two move in tandem with each other. So, having too much insulin or hyperinsulinemia can lead to high amounts of testosterone or male hormones and therefore lead to PCOD. That's why your doctor is prescribing metformin, which improves the insulin resistance, reduces the amount of insulin needed in your body, and therefore they're trying to reduce the testosterone. But you can do one step better. You can actually balance your meals, and you can make sure that you're getting the right balance between carbs, proteins, and fats. And you no longer have insulin resistance. So you neither need the metformin nor do you have PCOD.
One of the lesser known symptoms of PCOD, because we don't talk about it that often, and there is somebody who asked this question, is very sluggish metabolism. either leading to one, weight gain, or leading to serious levels of fatigue. So just take us through why this happens.
Sure. So the beauty of the human body is, we say that most of us, at least Indians, are at the most 6 feet tall, right? So within those 6 feet, all the functions that are necessary are done by a limited number of chemicals inside your body. So your reproductive hormones don't just have a reproductive role, they have many other side roles that they're meant to play. And this is not known to a lot of people. So for example, estrogen has the role not just of ensuring that your egg is released or it matures in your ovary and it comes out, or that your endometrial lining forms properly every period. That is its primary role. But estrogen is also responsible for skin health. It is what gives ladies their curves. It is what keeps skin supple. And during the first half of the period, it actually gives you a lot of ability to handle stress. The reason that a lot of women during menopause find it suddenly difficult to multitask, right? So, India, literally, the Devi is depicted as having 10 hands. The man is rarely depicted. Shiva on occasion is shown with 10 hands, but in general.
And women multitask. Please admit this. Far better
Yes,
than men.
absolutely. And there is a biological reason. Estrogen has
True.
recently been discovered as the multitasking hormone. That is why when estrogen fades in menopause, women find it difficult to do the 10 things that they could do earlier when they weren't in menopause. There's something on the stove, the child is crying, there's office work on the laptop, the servant asks for something. Everything the lady is able to do because of estrogen, right? So similarly, progesterone has certain roles to play in the second half as well. So when it comes to metabolism, weight gain, weight loss, any imbalance of reproductive hormones will have an impact there as well, because these two hormones have a crucial role to play in weight loss as well. So progesterone, for example, which is supposed to happen in the second half of the period, and that is the hormone that is often compromised in women in PCOD, is the one that is supposed to remove excess water from the body. It's the diuretic hormone. So women who feel bloated just before the onset of periods will often have anovulatory periods and have a progesterone deficiency, which then leads to a relative estrogen excess. And therefore, the hormones are not just playing a reproductive role, but they're playing a crucial role in your metabolic health, in your mental health, in your ability to multitask. So, never think that this is just a reproductive hormone problem and we'll fix it with reproductive pills. That's not how it goes. If you fix the root cause, it'll all get fixed. And if you don't fix it, then you can only put band-aids.
Absolutely. No, so true, Mahesh. I think this is such valuable information. In fact, along this line, one of the other questions that I want to ask you is there any connection between PCOD and thyroid? We've seen so many patients of ours who've come with, usually, and most of them have come with hypothyroidism, right? I would say at least 25 to 30% of our clients have that. So, what's the correlation, if there is anything at all?
Yeah, so there is a lot of research emerging on this topic, Shata, and that's the beauty of the Western sort of model, is that at least there's constant research that's happening, and especially with functional medicine, the kind of systemic medicine that we practice, there is a lot of new research that shows there was always an association between hypothyroidism and PCOS. The question was, does hypothyroid cause PCOS or does PCOS cause hypothyroid? That's all the question was. That the fact that the two seem to go together has been known for a good 40 years at least, according to me, in the research that I have seen. What new data has emerged, and this is the startling part, is that we are now discovering that thyroid tests, even done by the best lab and prescribed by the best doctors, are unable to truly reflect whether or not your thyroid is working well inside your cells. This is the startling revelation. This means that when women come to us with PCOD and a normal looking thyroid report, earlier we would say, hey, maybe there's no connection. Now we are questioning whether they have normal looking thyroid in the blood test, but the thyroid hormone is unable to enter into the cells, including the ovarian cells, where it's unable to do its job well. So we have had, certainly in our infertility cases, when they come to us with PCOD and infertility, the first thing we optimize is their thyroids. As soon as we optimize their thyroids, their PCOD goes away, their infertility resolves. So there is a big new learning that's coming in, that blood tests for thyroid are not always reliable. Doctors need to look for symptoms as well, and several people may show symptoms but not have blood tests that show, out of range. So you need to treat the patient, don't treat the labs. Look at the patient, see if they're feeling sluggish, if they have a 3 p.m. drop in energy. Funny things which old doctors used to see is the outer third of the eyebrows missing. You make the patient lie on the bed and you hit them with a rubber hammer, which we medical rubber hammer, and see how fast their tendon is, sort of delivering a flex. Women who have repeated sore throats, women who have repeated UTI, will often have undetected hypothyroidism. The old doctors knew this, so they would not rely blindly on the blood test. They would go by what they saw in front of them. So yes, there is a deep relationship between hypothyroidism and PCOD.
Amazing. So fascinating. Back to our thing that every organ, see, this is my, concern that when you go to a specialist, the specialist only looks at the organ in which they are specialized. But that's not the way the human body is structured, right? All our organs are intermingling. We have a trillion cells. Even today, scientists are not able to say why certain things happen to us. So the least we can do is to understand this interplay between organs or organ systems and ensure that we address that as a whole rather than addressing a specific symptom or a specific organ. There's one question. What is the side effect of having Normos tablets?
Having birth control pills or hormonal pills, right?
Normos, yeah, NO.
Normos. Okay, all right. Yeah, so all of these pills contain something called synthetic hormones, right? So what are synthetic hormones? Synthetic hormones mimic the molecular structure of hormones that are naturally made in our body, but usually with one or two bonds that are crucially different. So for example, a lot of women are told they're being given progesterone in the pill that they're being given, whereas truly what they're being given is something called a progestin, not a progesterone. What the body naturally makes is a progesterone, whereas what you get in the pill is a progestin. And these, things which are made in a chemical factory, and we try to mimic nature, don't mimic nature 100%. So there are always small side effects that begin to accrue, and over a period of time, these can lead to a lot. If you want to know what the true side effects of Normos are, all you have to do is to either go to the manufacturer's website, and they would have buried it somewhere, or you pull out the leaflet that comes with the medicine, and in really tiny microscopic print, you will have a list of 500 expected side effects, starting from nausea to digestive distress to weight gain to finally the 500th one is usually the very problem it's supposed to fix, to menstrual irregularities. So they know fully well that this is what it can do with long-term use. Unfortunately, none of us has the time. We all want the headlines. So we go with what our doctor tells us. And there too, I wouldn't blame the doctors. There is a lot. See, I tell a lot of patients this. The reason Sepalika sounds so different is that we are moving with the research of the day. But conventional medicine moves slow because it works on a do no harm kind of method. Something has to be proven across hundreds of studies before it makes it into a textbook. Then that textbook has to be taught in a medical college. Then a doctor's got to graduate with that knowledge. Then there's got to be a pharmacological agent that fits that knowledge and they're able to prescribe. So it's a good 50, 60-year-old year process before something that's there in the research makes it to so-called mainstream or corner medicine. You go to a clinic around the corner, you're not going to hear that in a hurry. So I would say, there are a lot of side effects that even the manufacturers know, even your doctors know, but since better solutions are not taught to them, they don't know yet how to fix it.
Right. Yeah, absolutely true, Mahesh. What is the, earlier you talked about LH and FSH. what is the ideal ratio or for these two? What is it that you look out for?
So, reproductive hormones and all hormones for that matter are continuously varying, right? So, when we check for reproductive hormones like LH and FSH, it's usually a day 2 or a day 3 number that we look at. And on the day 2 or day 3, ideally, the ratio between LH to FSH should be 1:1. And that's the sort of ratio that we look for. Once it becomes a 2:1 in favor of either, then we say there is a serious imbalance to look out for. So in a lot of ladies with PCOD, the ratio will be in a 2:1. In a lot of people with even early ovarian failure, the ratio will be 2:1, but this time more in favor of LH in some cases, FSH in others. It's quite a complex kind of picture.
Right.
In general, if you want to know the thumb rule for lay persons, then on day 2 or day 3 of the period, the FSH to LH ratio should be 1:1.
Right. And also, I guess, the importance of doing some of these hormone tests only on day 2 and day 3, because we've had so many cases where clients, just because their doctors have told them, they've gone and done these tests, or sometimes even on their own. And the hormone tests, if it's not done on day 2 or day 3, very often don't make sense, or we're not able to read much into them and give them effective points from them. Right?
Of course, the one exception to this rule would be that if a lady is having a very delayed period and hasn't had a period for 3 months or 4 months, then we say just go ahead and get the LH FSH done on any day, because then that gives us a starting point. You can't wait for a non-existent period and the second day or the third day of that. So that's the only exception we make to this rule.
Right, got it. And Mahesh, what is the implication of someone having high prolactin levels?
Okay, so as the name suggests, the term prolactin means prolactation. It is again a pituitary hormone, which means it's secreted from your brain. And when there is a high level of prolactin, which is supposed to happen only in lactating mothers. So the whole idea of a prolactin is a mother who is breastfeeding a child should not get another period, so that while this child is still young and needs intensive care from the mother and nutrition from the mother, there shouldn't be any chance of that mother falling pregnant again. So
Right.
prolactin rises as soon as a baby is born to prevent the mother from actually having another baby. Now, what this means in people who are not trying to have babies or haven't had babies is that if for any reason the prolactin is elevated, the rest of your body reads this as a signal that I should not produce regular period cycles. I should not have ovulation at day 14. I should not produce a regular period. And therefore, high levels of prolactin lead to irregular and usually delayed periods. The one important thing to remember is high levels of prolactin can also happen from very high levels of stress. Like I said, all hormones in the body, like ladies, are multitaskers. So prolactin has the job of actually helping a mother produce sufficient milk for her child, but it also has the job that if you're extremely stressed, it should again prevent you from becoming a mother. So very high levels of prolactin can even come with prolonged stress, and that can again lead to you not having periods. The only extreme case, and just in case somebody's asked a specific question, it's important for them to know, the odd outlier here is that it is possible to have a tumor which is called a prolactinoma, and that can lead to secretion of excess levels of prolactin, but that will usually be in the hundreds. It will be like 500, 600 levels of prolactin, as opposed to stress induced prolactin, which is likely between 50 and 100, or a lactating mother where it will be somewhere between 150, 200, etc.
Got it. So then how does one control? Is there a way by which we can control these prolactin levels?
Yeah, so if it isn't a tumor and if the lady isn't truly lactating or breastfeeding, then just bringing down the stress levels in life will lead to the prolactin coming down, so that your brain no longer perceives a threat which should prevent you from having a period or having a child.
Got it. One of the things that I've seen is that at least 20% of the patients who've come to us have been teenagers, young girls. Young girls, the age of 14, 15, having been put on contraceptive pills. So why is it that at such a young age, now let's assume that, when we started off, we said PCOD is a lifestyle disorder. I'm assuming that happens when you're, let's say, in your mid or 20s or late 20s. You're just 14 or 15. What kind of lifestyle disorder would have set in so soon? And secondly, assuming, so that is one question, but a related question, since I'm talking about young girls, is that if we manage to treat PCOD in these young girls, can it recur as they get older?
Sure. Okay. Again, very valid questions, both of those. Just remember, Sharda, you and I are sort of, on this side of the hill, as it were. So 14 and 15 at our times used to be rather innocent times, right? So even if we had some academic pressure, it wasn't at the crazy levels where it's at right now, right? So kids need to be achievers, overachievers. Not only do they have a real life, they have a Insta life, they have a Telegram life, they have, all sorts of personas. So they are literally overstimulating themselves all the time. That is number one. Number two, can you remember occasionally being given like a weekly allowance to go and have a pastry, and that was such a crazy treat? Today, you can't walk into a Starbucks and find anything other than a black coffee straight, which doesn't have sugar in it, right? So if everything you touch is going to have sugar in it, that's going to lead to high insulin levels, and that's going to obviously, like I said, lead to high testosterone, and it's going to lead to PCOD. That's one. So that's the first kind of PCOD. Second kind of PCOD we described is when the adrenals are overtaxed because you have so much stress. Is this angle just right? Oh my God, why does my boyfriend's status say it's complicated? So it's endless, right? So you've just got the number of challenges that young people face today is just crazy. And on top of all of this, they've got to ace their academics as well. So now you've got a perfect setup for adrenal PCOD. And, so you've got at least two types of PCOD that already, which we never had when we were youngsters. And now you've got the environment. And then there's all the stimulation from the screens, the blue light that disrupts the hormone melatonin, kids sleeping at 2 and 3 in the morning, waking up at 12. There's just too many small things that add up to make the perfect storm. And so kids end up with really complex conditions like PCOD. And the unfortunate thing again, Sharda, is most of us now are affluent enough to quickly see a specialist, right? Nobody wants to see a GP anymore. You have a headache, you see a neurologist. You never go to a GP. And so this is the same thing that we do. 14-year-old misses 2 periods, you hit the gynac. The gynac asks her what's really bothering her, and the child is often not bothered about her periods. She's bothered about her acne, she's bothered about her weight gain. She doesn't have that zero size figure or whatever it is. And therefore, the gynac also realizes this kid needs fast results. And somewhere we're all complicit in this system. So the minute you give her the birth control pills, her acne disappears because no longer are her own hormones in play anymore. There are artificial hormones in the pill that mimic her entire reproductive system, and those take care of not having any acne. The day you go off that pill, the acne comes right back, right? So it's a rather vicious system we're all stuck in right now. So we really, as parents, need to educate ourselves and begin to kind of ask, is this the right thing? Should I be giving my child a birth control pill or an antidepressant at age 13 and 14? The sort of things that we're doing now.
Yeah. So maybe that sort of answers the second question I had, which is, depending on how you have treated the PCOD in that young girl, it will tell you whether it's likely to come back or not in the future, right?
No, absolutely, Sharda. And this is a question that we often get, right? So there are even young people who come on our program and they will follow the lifestyle and they will see the difference and they will write rave reviews. And then 1 year later, they've gone off to uni and they're doing a course somewhere and all of their lifestyle is gone. They've taken two majors, they're sitting up nights trying to do stuff, they're part of a social life, and the PCOD comes back. And then they write into saying, hey, why did my PCOD come back? The whole point of this is, it's like, that I remember seeing a funny cartoon once, I think it appeared in a doctor's journal, there's a man trying to do something like this and he says, doctor, whenever I do this, it hurts, So the point is, if you do that, it will hurt. The body is meant to have the right amount of sleep, the right kind of food, the right levels of stress. Until you follow that lifestyle, of course, your body loves to keep you healthy. But if you're going to keep abusing it for 3 months, 6 months, a year, and if you're going to burn the midnight oil and eat junk next morning and stay up with coffee, of course the PCOD is going to come back. Not just PCOD, all of it will come back. If you had diabetes, it will come back. If you had thyroid, it will come back. So it's like saying, stop doing this. And that's the answer, right? So it's not an easy answer to hear, but that's the truth.
Yeah. You've made a lot of references to, rather, you've used the word stress several times in the course of our conversation today. So does that mean that if I do a blood test, if I'm a PCOD patient, do a blood test, I will usually see high levels of cortisol?
Yes and no. It sort of depends. So if you're in the early stages of stress, then the AM cortisol will be high, right? So normally in the units that are used in India, we look for a range between 10 to 15 for 8 AM cortisol measure. So it could be, for example, in an early stage of too much stress, that the waking cortisol could be at 25 or 20 or thereabouts. But if that stress stays for too long, then the adrenal glands are no longer capable of producing cortisol at all. Then you see hypocortisol, where you start seeing levels of 5 and 7 when you wake up in the morning. So in all things in blood tests, we keep telling our patients there is a Goldilocks range. Don't think just because something is good means more of it is good. We get a lot of patients saying, hey doc, my HDL is 90. That's the good cholesterol, right? So I must have zero cardiac risk. No, that's not true. 55 to 70 is where your HDL needs to be. Even at a 75, it means something else is wrong. So too much of a good thing is also wrong. Too little of the right thing is also wrong. So adrenal AM cortisol can show either high or low depending upon how long you've been stressed.
Right. Okay. Because we spoke so much about stress and sleep, can somebody take melatonin as a supplement for PCOD?
Very interesting question again. And yes, indeed, melatonin is a supplement that is called for in certain types of PCOD. However, I would caution, like all hormones, first see why your own body isn't producing it. A hormone is something that your body needs on a daily basis to function properly. If there is a way to support your body to make that hormone correctly, then please try that first before you hit the melatonin. Of course, you're jet lagged, you're in a BPO kind of job, you need some relief. By all means, use the melatonin. But I would say, here's how it goes, right? Most people don't know all hormones are created from cholesterol. So, cholesterol's been vilified so much. Women are put on, every woman who comes to me after listening to a gym trainer has been put on some low fat diet that screws up her periods. And of course, the gym trainer doesn't know anything about it. Therefore, he's not, taking responsibility for it. If you take away cholesterol, you've taken away the building blocks of all hormones, including melatonin. All hormones, which are steroidal hormones, are created out of cholesterol. And all hormones that are aminases or protein-based hormones are created from protein. First, see if the cholesterol and the proteins are in adequate quantity. If they are, and despite that you're not creating hormones, then maybe yes, there is a call for it. Certainly for older people, people who want to be at peak performance despite being of a certain age, those are all perfectly valid reasons to want to take exogenous or outside hormones. But we would say first fix the basics, because otherwise your requirement of these outside hormones is going to keep increasing. Today it's 1.5 mg, tomorrow it will be 3, then it will be 6. When does it end?
Right. Yeah. Yeah. You just spoke about cholesterol, and we know cholesterol is made in the liver. Now, does PCOD affect the liver function or vice versa? Does a malfunctioning liver triggers PCOS symptoms?
Absolutely. So at Sepalika, Sharda, we also do magnet-based acupressure, right? So that is one of the ways in which we actually help to reset the whole system. And funnily enough, for polycystic ovary disease, the protocol that we use is from Chinese acupuncture, and it is called liver qi stagnation. So literally, when the energy of the liver doesn't move properly, when the liver begins to store too much fat and you get early stages of a fatty liver, it's almost always associated with the PCOD. And it feeds the PCOD, and the PCOD feeds the fatty liver back. So in several young ladies, we often recommend a good Ayurvedic tonic like a Live 52 for a limited period of time. Because remember, whenever there is a hormonal imbalance, the rule about hormones that we say in naturopathy is the body loves to use it and lose it. The body doesn't like hormones hanging around for too long. So once a hormone has been used, it goes to the liver where it must be broken down into its constituent parts and then removed. So that's the beauty of how hormones work. So if there is excess estrogen, for example, it's going and getting clogged in the liver. It isn't getting removed from the liver. That's going to cause a stagnation in the liver, and the next period is going to be even more painful.
Yeah, yesterday I was consulting with one of a fertility couples where the man has actually a fatty liver, and I was trying to explain to him the connection between fatty liver and fertility, and he couldn't even understand it. So this whole thing about fatty liver, insulin resistance, which means the hormones have gone into imbalance. Fatty liver also means with absence of good fats, cholesterol, and therefore there's an impact on testosterone and therefore sperm health. So how beautifully these are all connected, though. So yeah, so that's somebody's just answered somebody's question on the impact of a liver malfunction on PCOS. Mahesh, there are plenty of questions on thyroid. If I begin now, we will just end up for another 1 hour, and then all the stuff that we've told people about good sleep being so important for hormone health will go haywire. So which means that we need to schedule another session on thyroid, because I think it's a fascinating subject, as you mentioned, and you mentioned several times, and there are so many questions on it. So I am going to, pause our session here. I'm just saying pause and not stop, because I'm very keen that we do one session on thyroid and hormonal health, both not just its connection to PCOS, but thyroid in general as well, and also thyroid and fertility. So thank you so much. Been a fascinating 45-50 minutes with you, and tells me that we need to do more sessions, because I'm still learning new stuff from you after having worked with you for over 5 years.
No, thanks so much, Sharda, and thank you for taking all these questions and asking these. I'm sure it's so distracting on screen, etc., for you to be able to scroll and ask all of this. Thanks to everybody who stayed up so late in India. Those who joined us early from abroad, big thanks to you as well. I think the core in all this is the more we learn. Not everything that we've discussed today may actually register with you, but even if you take away one thing, that's one thing less that you're confused about. So build your foundations, eat good food, try to manage your stress a little better, sleep on time, which we'll let you do immediately after this. And we wish you always vibrant health and well-being.
Thank you.
Cheers. Bye-bye.
Bye-bye.